Thank you. Thank you very much. And thank you very much for inviting me to come and speak to you. So my brief was to talk about what do we know about stigma and discrimination already, and can an anti-stigma programme, such as the one that has been taking place in England now since the end of 2007, can such a programme change what we know already? And I should maybe just briefly talk about the two terms stigma and discrimination, first of all, because even in one language, people tend to understand different things amongst each other by these terms. Discrimination people often think of as something, for example, that employers do to people with a mental health problem. We use this term in a much broader way in terms of unfair treatment in any kind of area of life. And so it's really unfair treatment as a behaviour. And behaviour is just one aspect of stigma. And we think of stigma in terms of problems of unfair treatment, problems of knowledge or lack of knowledge or misinformation, and also in terms of attitudes, so which is not exactly the same as knowledge. It's more what you think you know and what you believe, and so there's a more emotional content to that. So, what do we know? Well, there are a variety of sources of information, and this is by no means exhaustive, I suspect. But thinking about this, these were the main sort of categories that I came up with. We can look at what kind of legislation we have across the world. We can look at social inclusion for things like education, healthcare, employment, but also other areas of life, for example, housing. We have a lot of public attitude surveys in different countries, and I'll be trying to summarise those later. We can look at media representation. There's been quite a lot of work, again, in different countries, looking at how mental illness and people with mental illness are portrayed by the media. And obviously we have evidence from people with mental health problems, although that is something that, comparatively speaking, is something that's been studied rather sort of late on compared to some of these other categories, starting with people like Otto Weil in the States. So just as a couple of examples, looking at discriminatory legislation, I've confined this to Europe. And I've taken a recent piece of work by the European Union Agency for Fundamental Rights, which was done for 2010, and it was looking at political participation in the European Union. And at that point, obviously things may have changed since then, there were 5 countries where political participation was classed as full, so there were no limitations of any kind for people with mental illness in terms of political participation. I'm happy to see, obviously, that Sweden and the UK are amongst those 5. And clearly, as I said, things may have changed since. This is definitely a moving area. And my second example is one example of how things are currently changing in this field. So earlier this year, we in England passed the Mental Health Discrimination Act in order to lift some exclusions for people who had been detained, so involuntary admission to hospital under our mental health legislation. And there were a number of exclusions in, again, different areas of life. You were not allowed to sit on a jury in a court. You were not allowed to be on a company board. You were not allowed to become a member of parliament. And you were not allowed to become the governor of a school. And clearly, not many people are affected by the exclusions about being a member of parliament or a company board director. But being ineligible automatically for jury service is something that obviously affects all adults. And at the school level, that again could be something that's very awkward or embarrassing for people if they want to be a governor at their child's school and then they discover that they're not eligible because of their mental health history. And so all of these exclusions were struck off, if you like. They were gotten rid of just earlier this year, I am happy to say. So, next category, access to education, employment and healthcare. It's well documented in many countries that compared to people with other types of disability, whether that's physical disabilities or intellectual disabilities, people with mental illnesses have higher rates of unemployment. So far smaller percentages have some kind of competitive employment. And his work in a number of countries, including the Nordic countries, has shown the life expectancy for people with severe mental illness is severely reduced for up to 10, 15 years, depending on the study. There's also, in many countries, a lack of parity in terms of access to mental versus physical health care. And as you go sort of lower down the income scale for a country, the more extreme this is. So in somewhere like the Scandinavian countries, the lack of parity is much less extreme than a poor country. So if you think about somewhere like Chad, they will have very little health spending overall, but there will be a particularly huge discrepancy between spending on healthcare and spending on mental health care. And last, in terms of delayed help seeking and diagnosis at onset, obviously that results in poor educational outcomes, so higher rates of dropout from education and less access to high levels of education, and clearly that then affects people's chances for employment. So, on to public attitudes. Here I am very much helped by George Summarise, who has done a recent meta-analysis and review of studies looking at public attitudes to mental illness over a number of countries. This was published last year in ACTA. And they looked at studies published before 2011, examining time trends and attitudes with a follow-up of at least 2 years, using nationally representative population samples. And out of the 16 studies included in the review, they found six that fitted the criteria to do meta-regression. And the results, I think, are very interesting because there's a general trend to a greater level of mental health literacy, in particular towards a sort of acceptance of a biological model for mental illness. Obviously, the different surveys will ask maybe about mental illness in general, or they might ask about schizophrenia and depression. But regardless of what terms are used in these surveys, then people increasingly over time agree with the idea that these are brain illnesses. However, over the same time period, there's been little, and if anything, a negative change in terms of attitudes towards people with mental illness. So the idea amongst some of my more sort of biologically oriented research colleagues at the Institute of Psychiatry that once we understand more, then stigma will just go away, seems to be tinged with wishful thinking as far as the evidence to date would suggest. So that the increasing public understanding does not automatically result in better social acceptance of people with mental illness. In England, if anything, there was a decline in public attitudes in the years preceding the Time to Change campaign, which I'm going to talk about later. These are just individual items from our national survey that's done every few years. The Attitudes to Mental Illness survey that's funded by our Department of Health. We haven't been able to get the original data set and look at the scale altogether. But these are some representative items, and you can see that between 1993 and 2003, the scores in terms of the agreement with these items are going in the wrong direction, so that a smaller percentage of people in 2003 agreed with the idea that we need to be more tolerant to people with mental illness. Fewer people agreed that people with mental illness has been ridiculed for too long. Fewer people agreed that people with mental illness deserve our sympathy. And more people were agreeing that people with mental illness are a burden on society. Our interpretation of this change has to do actually with media representation, which I'm going to talk about in a moment, which gave a lot of negative coverage to cases particularly of homicide by people with mental illness. And it was very much put into the context of the policies of community mental health care, and the headlines were, community mental health care has failed, another person freed to kill, that kind of thing. So, as I said, things were going in the wrong direction, although later on they began to stabilise. But certainly there was no evidence that attitudes were improving at all. In terms of media representation, there are a couple of studies that I can tell you about, again from different countries. A recent one in the Canadian Journal of Psychiatry by Rob Whitley, and they looked at a huge number of newspaper articles between 2005 and 2010 and coded the main topic of each one, finding that 40% of them were about danger, violence and criminality, while only 19% were anything to do with treatment, and a similar proportion, small proportion, were about recovery or rehabilitation. And the vast majority had no quotation from anybody with a lived experience of a mental health problem at all. And significantly, they found that there were no changes over this 5-year period. And their conclusion, carefully worded, that there was scope for more balanced, accurate and informative coverage of mental health issues in Canada. In England, we always tend to think of our own newspapers as being particularly bad at coverage of mental health problems, but clearly we're not the exception, and Canada's not dissimilar. For the UK, I and some other colleagues, led by Robert Goulden, looked at samples of articles, not quite such a huge number as Rob Whitley, but we looked over a longer period of time, from 1992 to 2000 to 2008. And we did see some changes in terms of a reduction in the proportion of articles that were broadly negative about mental illness and people with mental illness. So our coding was somewhat different to Rob Whitley's. So instead of just looking at the topic, we tried to decide overall whether something was a more negative type of coverage or more positive. There was an increase over that time period in terms of the proportion of articles explaining, so providing information about psychiatric disorders and their treatment. But there was a difference in terms of what diagnosis the article was mainly focused on. So the coverage tended to become more positive if it was talking about depression, but remained largely negative if the topic was schizophrenia. So there seems to be a little bit of a divergence going on there. So in terms of evidence for people with mental health problems, these are just a couple of titles of studies done recently by colleagues in my department, really just to make the point that whether it's schizophrenia or depression, the experience of unfair treatment, again thinking about not just discrimination, for example, from employers, but looking at unfair treatment from health professionals, from housing, from the welfare benefits services, from friends, from family, in religious life. We look across a broad range of areas of life and have found that over like the 35 countries that are now part of this Indigo study group, the experience of unfair treatment is very similar across different countries. There isn't anywhere, where we should look to as a sort of model for better treatment. And again, whether it's schizophrenia or depression, the majority of people report at least one experience or one life area where they're affected by unfair treatment. So, coming on to time to change. First of all, acknowledgements to the very large team that has been working on this, and also to the people delivering time to change who help us to evaluate them. LEAP is the Lived Experience Advisory Panel who helped to advise us on the evaluation as well as on the delivery of time to change. Mind and Rethink are our two large mental health charities in England who deliver time to change. And the funders for the first 4 years were the Big Lottery and Comic Relief, and the main funders now are the Department of Health and Comic Relief. So, Time to Change describes itself as a new hybrid because it is not just doing sort of media type campaigning, so TV adverts or adverts on buses. They were doing a number of other things at sort of target groups as well as at the general population level. So one of the things that they wanted to do in the first phase from 2007 to 11 was to try to find legal test cases for discrimination, because typically, certainly in the UK, when somebody takes, for an example, an employer to court for discrimination on the basis of their mental illness, what usually happens is that there's an out-of-court settlement. And so there's a lack of sort of legal precedent being developed there. So they have tried to find test cases where people wouldn't settle out of court and therefore more would get written about the case, for example, in legal journals, and a precedent would be set. So judges would make judgments and the legislation would become more clear as a result. Having said that, what they have found repeatedly is that they would find a test case and then the person would settle out of court. So that part of the work did not progress in the way that they wanted to. The other parts of this were definitely more successful in terms of the delivery to the numbers, in terms of the numbers that they targeted delivery to. So there were two sets of local level activities. First of all, to give grants to local groups who wanted to do some kind of local anti-discrimination work, very often using the arts, like a theatre or making a film. And there were also a set of local projects which used exercise as a way to try and promote social inclusion. And that involved using funds to have people with mental health problems use local exercise facilities instead of doing something in a day centre. So those were the individual level wellbeing programmes. The Training Future Professionals was something that was done by the Rethink charity using an intervention called Education Not Discrimination. And they worked with 4 universities which had medical schools, doing an anti-stigma intervention with medical students, and also with trainee teachers. And I'll come on to that a little bit later in terms of the results. So, the targets for Time to Change that we, as the evaluation team, helped to monitor are a 5% positive shift in public attitudes towards mental health problems by the end of the first phase, which is last year now. And obviously we used the attitudes to mental illness survey that I referred to before, and that's now done every year instead of every few years. And also a 5% reduction in discrimination by 2012, and for that we use, again, an annual survey, but where we asked mental health service users about their experiences of discrimination. There are other targets which involved counting the number of people that Time to Change reached, but obviously they didn't need so much help from us with that. So in terms of our evaluation, as I mentioned before, we used the pre-existing survey attitudes to mental illness, but we added some of our own measures to that, because of our conception of stigma as being not just about attitudes, which are covered by the existing scale, community attitudes towards mental illness, which is in that survey. But we also wanted to think about knowledge, which is important in terms of its relationship to stigma, and also in terms of behaviour. So the closest we could get in terms of behaviour is asking people about current behaviour and intended behaviour, as well as disclosure and help seeking. So we added those bits. The reported and intended behaviour scale, the RIBS, is based on the idea of social distance. So it asks people about whether they live with or work with or live next door to or are in a relationship with somebody with a mental health problem, and what their future intentions are in terms of those relationships. And the mental health knowledge survey, the MAX, we ask about things like, do people think that medication can be helpful, psychotherapy can be helpful? Most people with mental health problems want to have paid employment. And there's a sort of a trick question which is worded the other way in terms of whether most people seek help, which obviously they do not. We use the same measures to evaluate the campaign specifically, so the mass media campaign that Time to Change delivers, which I'll show you one of their TV adverts in a minute. That comes in sort of bursts of a few weeks at a time, usually twice a year, and so we can do surveys just before and just after using a market research company to look at the same items to see how that changes from before to after the burst of activity. And time to get moving is actually, doesn't obviously sound very obviously like something to do with stigma. And again, that was something to do with getting people together, people with and without experience of mental health problems, and doing exercise together. And these were just sort of one-off events around World Mental Health Day. And the idea with those was whether they would promote disclosure and social contact between people with and without experience of mental health problems. So that is the population level evaluation. And here, I hope, is the film to give you an example of the... Okay, so that was their first TV advert, and I will now take you to a slightly later one. And while I'm finding it, I will add that this second one I'm going to show you has actually been remade into an American version, like some of our other TV and film productions in the UK. There is now an American version involving Glenn Close, who comes in at the end. So we feel like we're really taking off. Okay, so that's a flavour. Oh, don't stop again. No, stop, pause. Okay. In the American version, for which I have the link down here, it's identical, except the man obviously has an American accent and he's wearing a check shirt. And he's actually Glenn Close's, not everybody may know who Glenn Close is, which is a film star who was in Fatal Attraction and many other films. But her nephew has schizophrenia, and so she is behind the remaking of this film. She comes in at the end and gives him a hug and talks about the fact that it's time to talk about mental illness and to stop discriminating. So it's quite powerful as an endorsement. So I'm just going to go back there. Oh. It is too late. It is too late. I think we'll say no now. There. Okay, so here's a plug for the supplement to the British Journal of Psychiatry, which came out in April, which has a lot of the findings from our evaluation of the first 4 years of Time to Change. I'm just going to try and go through a few highlights before I finish. So some very key early results from the campaign. So, the films that I just showed you and the other advertisements in newspapers, that kind of thing. From the market research that we did before and after each burst of media campaign, it's very clear that being aware of the campaign, after taking other confounding factors into account, is related to better stigma-related knowledge. If you think about the max scale that I mentioned earlier, it's linked to better attitudes and also better intended behaviour. And as I said, that's after taking confounders into account, including social contact, which is the highest, the best, strongest predictor of these kinds of outcomes. So that was something that the people delivering Time to Change, and particularly the campaign, took note of very early on that knowing somebody with a mental health problem is really the strongest predictor of knowledge, attitudes and behaviour. And so the learning from this is that something that the campaign can do to assist its cause is to promote social contact. And I mentioned the Get Moving events where they try to do that by having people doing exercise together, although they've broadened that out now just to make it some kind of event where people can have contact with each other. So they need to promote that, and they need to measure the process of social contact, because it's not just about any kind of social contact. There are certain types of social contact that are more likely to reduce prejudice, and there's quite a long tradition of study, starting off with looking at racial prejudice and how that can be broken down. And typically if you have people on a very clearly sort of even level, so there's no hierarchical organisation between groups, and if they have a chance to get to know each other doing something together, particularly if they're working together towards a higher goal, then you're more likely to reduce prejudice. In terms of the various bursts of activity, media activity that there have been over the last few years, the awareness was higher in some of our ethnic groups than white groups, and particularly black groups, but lower in Asian groups. And at the same time, despite this higher awareness, then there's often less positive outcomes in terms of intended behaviour and attitudes associated with being non-white. And that has made the people delivering Time to Change think very carefully about whether there are parts of the campaign that need to be more tailored to different ethnic groups. It's not so much a question of awareness, obviously, for the African diaspora, but in terms of their response to it. Social contact, as I said, is a very key indicator, or thing that we need to measure because of the fact that it predicts better attitudes and intended behaviour and knowledge. And something that's very interesting that we've seen over the course of Time to Change is that social contact seems to be increasing. So before they started in 2008, over half of the population in the Attitudes to Mental Illness survey said that they didn't know anyone with a mental illness, including themselves, this was. And this has now changed so that the majority of people, it's a 14% increase, now say that they do know somebody. So there's an increased quantity of social contacts, and there's also evidence that the quality of that social contact has improved. So the evidence that we have for the better quality is that from the same survey and also from the campaign data, that people's intentions are more positive in terms of intended behaviour. And also from the Viewpoint survey of people with mental health problems, they report less discrimination from friends, from family, and more generally in terms of social life. So this, first of all, looks at the general public Attitudes to Mental Illness survey. You can see the green line at the top is the intended behaviour score from 2009 to 2012, and that's something that's improved a little bit. And again, attitudes have improved just sort of marginally, while knowledge really hasn't changed at all. And if you talk to the people who deliver Time to Change, they say, well, we're not primarily a sort of a literacy, a mental health literacy campaign. So that's not really a target. That's not a big surprise for them. But these other measures have improved. And this is from the campaign, where you can see a lot of the intended behaviour items have not hugely changed. They're just kind of going up and down at the top there. But something quite interesting is happening with one item in terms of people's willingness in future to live with somebody with a mental health problem, because that has just gone steadily up over the course of the campaign in quite a significant way. So just very quickly, the target group evaluation, we talked about the general public and the anti-stigma campaign. In terms of one target group, we look at Viewpoint for people with mental health problems, and we use the discrimination and stigma scale, and I will summarise that very, very briefly in a moment. For education, not discrimination, again, we use the same measures for knowledge, attitudes and behaviour. to look at the impacts of the anti-stigma training on medical students and trainee teachers and other education professionals. We've looked at press coverage to see how the media are responding to time to change. And we also did a survey of employers using a pre-existing survey that had been done in 2006. And last, we tried to look at whether the time to change site for employers and employees, where people could find out about their rights and about good practice in terms of managing mental health problems at work, whether people felt more empowered as a result of that. So I don't have time to go into a lot of this at the moment, but again, I'll try to highlight a few things. So this is from the Viewpoint survey, and it's using the score from the discrimination and stigma scale, which covers 21 areas of life in which people report negative treatment. And you can see that over the first 2 years, there was quite a big drop overall. This score takes into account the fact that not all areas of life are applicable to people. So, for example, if they don't have any religious beliefs, they're not going to experience any discrimination in practice of religion, for example. So the score has fallen, but as you can see, it's kind of leveled off over the last year or so, which is clearly a concern for time to change. These are the top 10 life areas that people reported discrimination in 2008 and then again in 2011. And as I said before, the big changes are where discrimination was most commonly reported. And obviously it's easier to find a significant change where you're starting from a higher level. And so more people report discrimination from friends, family, obviously because more people have exposure to friends and family. But that's where we've seen a significant drop. And initially we also saw a significant fall in terms of finding a job. That difference now is no longer statistically significant. And as I said, some of the measures, the indicators are starting to sort of go the wrong way or levelling off. And in terms of small increases that we need to again be aware, keep an eye on carefully, is a possible rise in the extent to which people are reporting unfair treatment in terms of welfare benefits and also their safety. Our interpretation for this is that over the course of time to change, obviously we have had a new government and a lot of austerity measures, including big cuts to welfare, and a kind of narrative that's been very prevalent in a number of national newspapers about people taking advantage of the welfare benefits system. So people who shouldn't be on benefits and were claiming them. And our concern is that this may be affecting people's attitudes and people's behaviour to people with mental health problems. So some key later results. Going back actually to the top 10, you can see that there's been pretty much no change in people's reports of unfair treatment, either from mental health staff or from physical health care staff. So that is something which hasn't shown the same pattern of getting better and then levelling off. It just hasn't changed at all. Consistent with this was that the anti-stigma intervention, which involved some role play and a talk by people with lived experience, although it had a short-term positive impact on the medical students, at 6 months there was no difference between them and a control group who had not had the intervention. So there clearly needs to be something else done to have any kind of an impact on health professionals, which the people delivering time to change are now thinking about. And they're instead working with the NHS Confederation, so they're sort of starting at the top with NHS managers now and perhaps the Royal Colleges, instead of sort of starting at the bottom with medical students who clearly don't have much ability to kind of change the culture of health services. In terms of our work on media representation, we've seen what seems to be a kind of a polarization in coverage of mental health problems. So we had the same proportion of articles which we felt overall were somewhat stigmatizing. That hasn't really changed. But at the same time, there's been an increase in more anti-stigmatizing articles. And that's at the expense of more sort of neutral or mixed articles. So, and there aren't many of those now. So articles tend to be either pretty positive or quite negative, with not much in between. And along with that increase in anti-stigmatizing articles, there are more quotes from people with lived experience and more quotes from the mental health charities. In terms of thinking about the future, as I said, that there is a question about whether the positive changes up until 2010, particularly as far as the viewpoint survey is concerned, not all of those positive changes have been maintained, and clearly the item on benefits is going in the wrong direction. So more and more people are reporting unfair treatment in terms of their receipt of welfare benefits, but also the whole process of claiming and in terms of how they're treated. So the implications, I will try to sum up. It seems like interpersonal behaviour change is possible, because we saw some quite big shifts using the viewpoint survey over the first couple of years, but it also seems to be somewhat volatile in that it's levelled off, and in some of those items it's starting to go sort of back in the wrong direction. And although I can't sort of show you all the figures for the last year of the viewpoint survey, we've got the 2012 results now. And that is really borne out because a number of those items are still heading again in the wrong direction. So we had quite a significant improvement in behaviour and then a decline. And at the same time, the attitudes and knowledge amongst the public have changed much less. So it seems like they're something that's much slower to change. Knowledge really hasn't changed at all, and attitudes have become slightly more positive. So in a way, they're no longer kind of moving together in terms of attitudes and behaviour. And it may be, as I said, because people think about people with mental illness in a slightly more positive way, and because particularly now that they're more likely to have social contact with somebody, they think positively maybe about that person. But in terms of attitudes towards people with disabilities who are on benefits, there's a different kind of shift in attitudes, and people may be adversely affected by that because of knowledge that they're on benefits, or an assumption that because they have a mental health problem, they're on welfare benefits. It's very clear that institutional discrimination is harder to change. If you think about the findings with health professionals, that's people acting, in their institutional role, and we saw no improvements there, whereas we did see initial improvements in more informal relationships, such as friends and family. And lastly, the importance, but also the limitations of social contact theory is something that's been very striking as the campaign has progressed. So the fact that social contact predicts positive attitudes so strongly, and yet the most common sources of unfair treatment are people who have social contact, i.e. friends and family. There's clearly more work to be done with friends and family, and more work to be done on social contact theory. Thank you very much. That's just another plug for our summer schools, which my head of department has asked me to add. There is one on stigma, I should say. That's it.